Good evening, ladies and gentlemen. Welcome to our Upper GI Surgery Virtual Grand Round 2021. This is a series of webinars organized by the Upper GI Training Committee together with Malaysian Upper Gastrointestinal Surgical Society, MUGIS. Today is a sixth series out of the 9 series actually we planned for this current Virtual Grand Round. Today's educational event is sponsored by Medtronic. Thank you, Medtronic, for making this event a success. The host center for today is Hospital Sultanah Aminah Johor Bahru. My co-moderator tonight is my close friend, Mr. Hans Alexander. He is a consultant upper GI surgeon and also the chairman for the Upper GI Training Committee. Mr. Hans, would you like to say hello to everybody?
It's all right. Go ahead.
Okay. So the agenda for tonight event will be started by a presentation by Mr. Beng. He is actually our currently our first year trainee in Hospital Sultanah Aminah Johor Bahru. Prior to joining HSA, he is a trainee. He is a general surgeon in Hospital Seberang Jaya. He will have a 20 minutes presentations followed by a short video presentation by our sponsor. The Q&A will be at the end of the sessions. Okay, there will be a few housekeeping announcements. Your outgoing audio will be muted during the webinar, so kindly type your question in the Q&A box. This webinar will be recorded for internal use. As such, your participations serve as a consent for the same. E-certificate will be sent to you at the end of the whole series. You may use this certificate as a proof of attendance to claim your CPD point with NSR or MMA. We will send you a survey link to your email after the webinar. Please kindly actually, send us back your feedback, which will help us to improve further on our webinar in the future. For any inquiry related to our sponsor products, you may leave the questions in the survey and the sponsor will contact you directly after that. So for your information, for tonight's event, we received about 600 over actually registrations. So up to now, I'm not sure actually how much actually we have actually had participated. So without further ado, I would like actually to invite Mr. Beng to present on our current on our sixth topic today, evolving options in the management of esophageal perforations. Mr. Ng, please.
Thank you very much, Mr. Lim and Mr. Hans. Good evening, everyone. I'm Chong Beng, representing the Upper GI team of Hospital Sultanah Aminah Johor Bahru. I'd like to welcome all the participants. I would like to thank you, our kind sponsors, for organizing this event. For today's discussion, we have selected a topic that's relatively rare compared with a PGU or PDU that I've talked before, but has historically proven to be of very high mortality and difficult to manage. We hope with the presentation today, you'll likely instill the awareness of the audience out there to this diagnosis and shed some light on the optimal management of this dreaded disease. We'd like to start with a presentation of an esophageal perforation case, which was referred to Mr. Kelvin Woon about a month ago. So this is a patient, Miss A. She's a 44 years old lady. She accidentally swallowed her dentures and only sought treatment on day 5. Subsequently, she underwent rigid endoscopy with denture removal under GA. During the procedure, the denture can be seen and removed, but we also noted multiple superficial mucosal laceration by the operating surgeon. True enough, post-op patient developed worsening tachypnea and chest pain. Chest X-ray was done, show right hydropneumothorax. Chest tube was inserted. So patient underwent urgent CT scan before referral to surgical team. The CT scan show features of acute mediastinitis and right hydropneumothorax. The patient was referred to surgeon. So at this point, I would like to call a pool. If you were the surgeon being referred this case, what would you do? Are you going to perform an endoscopy assessment yourself coming morning to look for perforation site? You're going to resuscitate the patient adequately, refer and transfer this patient as early as possible to center with upper GI surgeon without performing OGDS yourself? Or you want to discuss with a radiologist the next day the causes of the mediastinitis and hydropneumothorax? Please choose one. We will see the result later, but I will continue with my presentations. So she was referred to the upper GI team without further delay. Prior to the transfer, she deteriorated and subsequently intubated. She was started on tazocine, BP was supported on noradrenaline, chest tube drains cerebellum. She underwent endoscopy assessment by the upper GI team prior to the surgery. So this is an OGDS image. You can see the true lumen on the left side. The opening on the right is the perforation site. Further into the perforation site, you can see the tear pleura. Collapsed lung is visible here in the right pleural cavity. Further scope into the right pleural cavity now, you can see totally collapsed lung covered with fibrin and slough. And of course, thoracic empyema and the cerebellum fluid in the chest tube. So the diagnosis at this moment is cervical and proximal thoracic esophageal perforation with severe right thorax contamination with pus and slough. Patient had respiratory and circulatory failure requiring intubation and inotropic support due to the sepsis. So I will stop the presentation here. Let's go through some history together and we will come back to the subsequent management of this patient. I will start with the basic anatomy of the esophagus, which is important for the subsequent presentation later. The esophagus is a fibromuscular tube, about 25 cm long in adults, can generally be divided in 5 parts: the cervical, upper, middle, and lower thoracic, and the abdominal part. It's located at the posterior mediastinum in close proximity to many important mediastinal structures, namely the heart, trachea, left bronchus, arch of aorta, descending thoracic aorta, and many, many more. In OGDS measurement, the upper esophageal sphincter located at about 15 cm from the incisor. The thoracic esophagus starts at the sternum notch about 22 cm from the incisor, extend down all the way to the diaphragm. The abdominal portion extends from the diaphragm to the cardiac portion of the stomach, usually 40 cm from the incisor. The esophagus has 3 constrictions in its vertical course. The first constriction is at 15 cm from the upper incisor teeth, where the esophagus commences at the cricopharyngeal sphincter. The second constriction is at 23 cm from the upper incisor teeth, where it is crossed by the aortic arch and left main bronchus. The third one is at 40 cm from the upper incisor teeth, where the lower esophageal sphincter is located. These constrictions correspond to the usual level of foreign body impaction in the esophagus. The esophagus has the following 4 concentric layers: mucosa layer, submucosa layer, muscular layer, and adventitial layer. Muscular layer is formed by circular and longitudinal muscle fibers. The fourth and the outermost fibrous layer is formed by the external adventitia. Important for me to mention here is the esophagus has no serosa layer. It's important to know that there's about 5 cm of abdominal esophagus in the peritoneal cavity, covered with the peritoneum. Okay, let's get into the topic of esophageal perforation now. Dr. Herman Boerhaave, a Dutch physician, was the first person to describe spontaneous esophageal rupture and the subsequent mediastinal sepsis, based upon his careful clinical and autopsy findings. He described the dramatic presentation of spontaneous esophageal perforation of an admiral at his time and made the diagnosis during autopsy only. The admiral drank a lot of some sort of emetic and torn his lower esophagus after bout of vomiting. So obviously, it's fatal at that time and can be diagnosed only after the patient died. The first successful surgical repair of esophageal perforation was reported in 1947 by Barrett in London. In this paper by him in 1947, it stated that there can be few conditions more dramatic and more terrible. He also foresaw that the diagnosis and the treatment can definitely be improved in the future by these 3 points. First, a knowledge that the accident can and does occur. Second, a knowledge of the symptom. Third, an early diagnosis, which I think are very true until today. In his paper in 1946, this 46-year-old lady admitted to King College Hospital with spontaneous esophageal perforation. The perforation was closed with one purse-string suture of catgut. She was discharged after 2 weeks. Almost similar time in US, Olsen and Claggett reported a successful esophageal perforation repair also. In this patient with Bohawe syndrome, a left thoracostomy showed a 4 cm vertical tear at the lower esophagus. It was repaired with catgut and pleural buttress. He was also discharged well on post-op day 25. So since their time, the evolution of diagnostic technology, endoscopy, surgical techniques, antibiotics, and the critical care have tremendously improved the outcomes of esophageal perforations. Today, Bohawe syndrome accounts for approximately 15% of the perforations. It's most often due to an abrupt increase in the esophageal pressure following an explosive vomiting in the absence of relaxation of the superior esophageal sphincter. The tear is usually located on the left side of the lower third of the thoracic esophagus, and the wall defect is usually quite big. Iatrogenic perforation of the esophagus during diagnostic or therapeutic procedure represent the most common cause now. Perforation due to foreign body injection, trauma, operative injury, and tumors are uncommon and comprise a few remaining causes. As you know, OGDS is the most common endoscopy procedure now. Coupled with therapeutic procedure, they are currently the most common causes of esophageal perforations. So what are the principles of management for esophageal perforations? First, high clinical suspicion, timely and accurate diagnosis. Second, aggressive resuscitation with fluid and vasopressor if necessary. 3, start early broad spectrum antibiotic that cover aerobic and anaerobic. 4, source control, which means closure of the leakage and draining of contamination and collection. Number 5, establish a route for nutrition support. Enteral route is definitely ideal. Last, if there's exclusion or diversion or diseased esophagus requiring excision, reconstruction should then be planned after that. Why is expedient diagnosis so important here? As you know, esophagus has no serosa layer. Perforation of muscle will result in contamination of the mediastinum by gastric content and saliva, and then result in acute mediastinitis. If the pleura also rupture, the esophagus and the mediastinal contamination will be drawn into the pleural space by the negative thoracic pressure. In very short period of time, you can see the clinical deterioration of a stable patient to severe sepsis and then septic shock. Hence, prompt recognition and treatment of this condition is paramount to minimize local inflammation and avoid systemic sepsis that will result in significant morbidity and mortality. Chest pain, shortness of breath, odynophagia, subcutaneous emphysema are all major warning symptoms. Remember, acute mediastinitis kills, and it kills fast. Chronic mediastinitis is still a cause of 90-day mortality if acute mediastinitis didn't kill the patient. In this systematic review paper by a Finland author published in 2013, 75 studies from year 2000 to 2012 were analyzed. Full mortality of these almost 3,000 patients was 11.9%. So what I would like to highlight here in this paper is there's a 2.3 times higher risk of mortality in patients that were treated after 24 hours. Delay in diagnosis or delay in treatment is to increase the mortality. Another older paper by Brinster in 2004, in a case series of 559 patients, highlight how delay in treatment more than 24 hours result in doubling of the mortality rate. Fortunately, we certainly came a long way from making a diagnosis from post-mortem autopsy in the Bohawe era, chest X-ray only in the Barrett era, to L1 CT scan in our time, allowing us to make an early and accurate diagnosis. CT scans are important to visualize where the likely injury is, and where the contamination has traveled. It's very sensitive in detecting perforation and help to assess extension of contamination to adjacent structures and to guide initial therapy of repair and drainage of or diversion if repair is unlikely. It also eliminates other conditions that may mimic perforation, namely aortic dissection, esophageal intramural hematoma. In selected cases, contrast-enhanced esophagogram help localize the perforation and spread of contamination. Barium is not recommended here. It's difficult to wash out, so we usually use gastrography. What about the role of endoscopy in diagnosis? It's reliable and safe in experienced hands, useful to confirm the location of perforation and assess feasibility for endoscopic treatment. On the other hand, there's potential risk of enlarging the perforation size and aggravating the contamination of surrounding spaces. So please note, a chest tube may be inserted prior to scope, and equipment should be made available in case tension pneumothorax occur due to insufflation when you do endoscopy. Necessary item for chest tube insertion in the endoscopy suite is a must when you perform endoscopy for esophageal perforation. You may need to intubate the patient post-OGDS, so the necessary equipment must be available. The next principle is patient needs to be aggressively resuscitated, as they are usually in extremis on presentation. Patients should be resuscitated according to the Surviving Sepsis Campaign guidelines. After the patient is adequately resuscitated, we should now address the source of infection. Surgical management remains the anchor of management in source control, sometimes in combination with endoscopy and radiological method. Now you might want to ask the question of which surgical procedure is the best for esophageal perforation patients. Let's look at one very old paper for comparison. This is a case series of 127 patients with esophageal perforation from 1937 to 1984 in a US center. 13 patients were diagnosed during autopsy only. 114 patients diagnosed clinically and underwent treatment. So primary closure was performed in 49 patients, followed in frequency by operative drainage, non-operative treatment, and resection. With the exception of the non-operative treatment, you can see survival for all the groups were improved for patients treated within 24 hours. The most favorable outcome is here. A 92% survival was seen following primary closure within 24 hours. So primary repair has the best outcome if early detection. In this cohort, the overall mortality was 21% at that time. So in this paper by Brinsley in 2004, the case series between 1990 to 2003, total 559 patients, show the lowest mortality in patients treated with primary repair, which is 12% amongst the other surgical interventions. Now to this Finland group paper published in 2013, you can see primary repair mortality has improved over the year, down to 9.5%. This is due to improvement in diagnosis, availability of expertise, better ICU care, nutrition support, and of course, intervention radiology. Primary repair, if feasible, should be the procedure of choice. So general principle in performing primary repair: number one, excellent exposure. Need to debride the non-viable tissue, close the defect, use buttress to reinforce the esophageal sutures, and finally, adequate tube drainage. The surgical approach or access should be tailored according to the location of the esophageal perforations. So for esophageal perforation located in the neck, a direct repair of the esophageal defect should be attempted whenever feasible. The esophagus is approached through a neck incision along the anterior border of the sternocleidomastoid. Or if bilateral exploration is required, you do a collar incisions. There are two ways to access to the cervical esophagus with sharp and blunt dissection. For thoracic esophageal perforation, access to perforation in the middle third of the esophagus is through a right thoracotomy in the 5th or 6th intercostal space. Perforation in the lower third is best approached through a left thoracotomy in the 6 or 7 intercostal space. Perforation at the esophageal gastric junction can be assessed by either a left thoracotomy or upper midline laparotomy. So always remember this, the mucosa defect is often larger, longer than the mucosa tear. The principle of repair is debridement of necrotic tissue, full exposure of the mucosa defect after longitudinal esophageomyotomy, approximation of mucosa and some mucosa edges over a bougie in a tension-free closure. Muscular layer is then reapproximated using a running or interrupted absorbable suture. Buttress with variety of vascularized autogenous tissue and adequate drainage. So the necrotic tissue should be thoroughly debrided till healthy edges are seen. Full exposure of the mucosa defect after longitudinal esophageomyotomy. And then repair in 2 layers, if possible, over a bougie. Whereas healthy tissue with good blood supply can be used as buttress to reinforce the repair. In abdominal esophageal perforation, fundus can be used to wrap the repair like how fundal plication is done. If primary repair is not possible at the time of surgery because of patient is hemodynamically not stable because of severe mediastinitis, or in delayed surgical exploration, patient with extensive esophageal tissue damage, or patient has underlying esophageal pathology like perforated tumor. So T-tube can be inserted into the esophagus and bring out to outside in this manner. The T-tube creates a controlled esophageal cutaneous fistula, allowing drainage of the esophagus and time for surrounding tissue to heal. But usually it fails tragically and not really recommended. For patients with extensive tissue damage or not fit for thoracotomy procedure, we have to perform exclusion of the esophagus and diversion of the saliva and gastric juice. So traditional technique includes cervical esophagotomy, gastrostomy, jejunostomy, followed by mediastinal or period drainage. The idea is exclusion of the perforated esophageal segment to prevent further contaminations. Second, reconstructive surgery is needed to restore the continuity, which usually is done months later. So in this modern era, of course, the advancement of the laparoscopic technology has allowed us to perform repair with minimal invasive technique. So for thorax, we can do VATS or thoracoscopic surgery. For abdomen, laparoscopic surgery. It gives the proven short-term advantages of minimal access surgery, such as early ambulation, less post-op pain, and shorter length of hospital stay. Minimal invasive thoracoscopic surgery offers a magnified view of the entire thoracic cavity and excellent access to all mediastinal compartment. And usually we employ approach through 3 or 4 trocar positioned conventionally through the chest. Is there any evidence of MIS for esophageal perforation? Look at this paper published in Surgical Endoscopy in 2019. 10 spontaneous esophageal perforation between 2012 and 2018 at Mercy University Hospital, Cook Islands. Out of the 10 patients, 2 underwent right thoracoscopy, 8 underwent left thoracoscopy, 8 repaired primarily without T-tube, 2 repair over T-tube. All the 10 patients underwent laparoscopic feeding jejunostomy. So the mortality rate is actually comparable with open repair, which is 10% only. So with the good clinical outcome, in a cohort of a high-risk patient, the author concluded that minimal invasive surgical management of spontaneous esophageal perforation is feasible and safe, and with outcomes which compare favorably to the published literature. After surgical treatment, we will look at endoscopic treatment. Endoscopy is one interesting field that is undergoing invention and innovation every day, and has helped us in managing esophageal perforation, both in diagnosis and treatment. Endoscopic clips, which traditionally been used for hemostasis, is now designed in ways to close mucosa defect. It may be used as first-line therapy for acute spontaneous esophageal perforation and iatrogenic perforation. Remember, clips only work if the mucosa is healthy and can be approximated without tension. If the mucosa is edematous or is under tension, it will usually fail. Recently, there's new invention of the bare trap light over the scope clip. That over the scope clip able to circumvent many of the limitations of the through the scope clips and allow for closure of large perforation not amendable to closure with conventional clips. So an example of over the scope clip in a Japanese case report. Next important invention of the last century was the endoscopic stent. In 1959, Celestine described the palliation of esophageal malignancy with a plastic stent introduced at laparotomy to bypass the esophageal cancer. So the last 3 decades have witnessed a tremendous growth in the indication for endoluminal stent. Stenting requires there be some constriction for the stent to have purchased. Migration is a major complication in stenting for esophageal perforation. So this is a stent migrating into the stomach, fear to protect the repair, plus there's nothing for the stent to maintain its position. So let's look at the evidence. It's a retrospective study published 2013 by a German group. Study was done in a British and a German high volume center, total 38 patients with Bohavé syndrome from 1990 to 2011. In 11 of 13 in the stent group, operative intervention was eventually mandatory, and 3 of 13 even required repeated surgery in the stent group. So stent doesn't have good outcome in the cohort of patients. Conclusion by the author is management of Bohavé syndrome by means of endoscopic stent insertion offer no advantage regarding morbidity, intensive care unit or hospital stay, and is associated with frequent treatment failure eventually requiring surgical intervention. Furthermore, endoscopic stenting show a higher risk for fatal outcome than primary surgical repair. Here's a collection of recent case review for endoscopic stent placement. There are no randomized prospective trials, just multiple retrospective multi-center and single-center case series that show clinical effectiveness ranging from 63% to 89%. The most common complication is stent migration, which occur in 8.8% to 40% of stent placement. The mortality in this series range from 0% to 17%. Another new technique is endoluminal vacuum therapy. It was originally described in 2003 for the endoluminal treatment of rectal anastomotic leak. The technique was adapted for use in the upper GI tract later in the last decade. EVT is known in the literature by several different names: endoscopic vacuum therapy, endoscopic vacuum assisted closure, and endosponge. So EVT therapy is limited only by the size of the sponge used and can be placed intraluminal or intracavitary. EVT can be DIY. You usually change every 3 to 5 days. It depends on patient condition and size of the lesion. The endpoint of the therapy should be the appearance of healthy tissue or shrinkage of the defect to the point at which the spine no longer fixed in the lesion. Here is a collection of studies of EVT. You can see here 3 are prospective studies. The result appears more promising and better than the stent insertion. It's mostly used for anastomotic leak here. Now you will be wondering which modality is better, stent or EVT. This is a systematic review and meta-analysis by Italian group. There's 4 studies including 163 patients. Esophageal leak closure rate is 5 times higher with EVT. EVT has shorter treatment duration, lower major complication, and lower in-hospital mortality. Another systematic review and meta-analysis by a German group. There are some overlapping of study included between the 2 systematic reviews, also show similar results. The latest evidence shows that EVT has a lot of advantage compared with stent placement. However, there's currently no study that directly compares EVT and surgical treatment in esophageal perforation. To sum it up, from all the evidence that we have seen so far, I would like to use this algorithm as a guide for esophageal perforation management. It can generally be divided into the cervical and thoracic abdominal pathway. In the cervical pathway, in contained perforation, we will MBM the patient, put on parenteral nutrition, or give enteral nutrition where NG tube is visible, and starts antibiotic. If the patient improves in 1 week, we'll proceed with contrast study to look for leakage, followed by endoscopic assessment to assess the healing process. If patient doesn't improve in 1 week, surgery as in primary repair and drainage is usually life-saving for the patients. For uncontained perforation, as in free drainage into the mediastinal cavity, or the patient is really in severe sepsis, surgical exploration, repair, and drainage is definitely the treatment of choice. For thoracic abdominal perforation in patients with a healthy esophagus and contained perforation, non-operative management can be tried in very selected few patients with evidence of perforation still with oral contrast study and no ongoing sepsis. In patients with favorable anatomy or iatrogenic perforation during endoscopy procedure, endoscopic closure with clips and stent can be attempted. For uncontained perforation in thorax and abdomen, surgery is definitely warranted. Patient is stable to go for surgery. Primary repair is the procedure of choice. If during surgery, patient was unstable or extensive tissue damage precludes primary repair, T-tube can be inserted. Exclusion and diversion is done in really bad tissue damage and unstable cases. Disease esophagus will need resection, depend on what was the disease, usually in a delay manner after control of sepsis and restoration of the patient physiology. I would like to emphasize again here, after diagnosis, resuscitate the patient adequately, start antibiotic, and transfer as soon as possible to UpperGI Referral Center. Time is go for this group of patients. So now back to our case. To recap again, this patient had cervical and proximal thoracic esophageal perforation with severe right thorax contamination and was intubated and with inotropic support. So I'd like to conduct a poll here again. What would be your management as a surgeon if you are the managing surgeons? So please choose one. Okay, let's see what did we do for the patient. So the patient underwent right neck exploration, primary repair of the esophageal perforation, followed by right thoracoscopy exploration, on-table OGDS, period defect repair, washout, and decortication. So you can see a 5 cm linear tear of cervical esophagus extending to the upper thoracic esophagus here. This is neck incisions. So the esophageal perforation was repaired in 2 layers. The sternocleidomastoid flap was used to buttress the repair site. You can see the right recurrent laryngeal nerve there, identified and preserved. Patient then is turned left lateral semi-prone positions, underwent right thoracoscopy exploration on table OGDS, period defect was repaired, and decortication was done. So you can see the period defect here, identified, debrided, subsequently closed. So before closure, you can inspect the esophageal repair site, the period defect there. You can see the blade drain that came down from the neck. So finally, decortication is done to prevent the lung entrapment. So what happened to the patient? Patient was extubated post-op. Post-op day 1 started on NG tube feeding. Post-op day 2, one of the chest tube was removed. Post-op day 4, she was allowed resource drink and water. Post-op day 6, contrast study was performed. There was no leakage of contrast. She was allowed polymeric formula feed through the mouth. And post-op day 9, she was discharged well. So what can we learn from this case? See the initial part of the management, failure to recognize esophageal perforation after the rigid scope, result in delayed diagnosis. It probably cost the patient life. Remember, acute sinusitis kills fast. This patient was fortunate to have a perforation at the cervical esophagus. Just her repair was not left in a hotbed of sepsis. If the perforation is in the thorax, the patient will definitely experience more turbulent clinical course. The thoracoscopic washout and decortication done by an experienced surgeon saved the patient from prolonged mediastinitis. CT scan here is important to determine where the collection has tracked to either the left or right thorax. So although the guidelines have not made a clear stance, flexible endoscopy might be preferable to rigid endoscopy, as we have high resolution image now. We have a few range of armamentarium or accessories to perform retrieval of foreign bodies. So in cases of foreign body referred to you, you can attempt endoscopic retrieval with flexible scope as long as the expertise is available. Those impacted sharp objects likely result in laceration. Please do refer to the UpperGI surgeon. Foreign body should not routinely be pushed down into the stomach. And it's very important for you to know what it looks like before causing more injury. This is an example of denture that we removed about 2 months ago in Johor Bahru, endoscopically. So let's look at the first pool result. Okay, so I'm glad that 85% of the people will send the patient as soon as possible to UpperGI surgeon without performing OGDS. Okay, very good. Yeah, immediate referral to UpperGI team. There's no need to perform OGDS to confirm diagnosis. The symptoms and the CT evidence of acute mediastinitis post-endoscopic procedure is sufficient to make the diagnosis of esophageal perforation. Okay, second pool result. Okay, yeah, 12% choose non-operative management. It's not really an option here because patient is really ill and septic. Endoscopic stent or clips is the defect is too big for the clip or stent. Luminal vacuum therapy also the same. It's don't forget the sponge need to go through the oral cavity to reach there, so the defect is a bit too big for that. The last two reasonable option depends on the patient condition. So primary repair, adequate drainage of contamination give the best outcome, of course. But sometimes, if the patient is in worse condition than this, diversion and exclusion to save patient life, treat the mediastinitis, and come back and recon later, probably life saving, rather than we attempt primary repair and the patient repair broke down later, then it will be a turbulent clinical course. So far, how far have we evolved here? So surgical repair here has stood the test of time. Okay, you can see surgery is the intervention of choice for most of the cases. For minimal invasive surgery, it really gives good early outcome with less pain, early mobilizations, and shorter hospital stay. The new endoscopic technique with more advanced technology give the surgeon new option in managing esophageal perforations. And don't forget IR, which is invaluable as adjunct to all the above methods. And of course, we have better diagnostic tool now to detect and diagnose early and accurately. And we have intensive care to care for critically ill. We have broad spectrum antibiotic and multidisciplinary support. So in conclusion, and also take home message to everyone here, from identification of perforation as the cause of a patient problem, resuscitation and timely choice of a therapeutic approach are keys to maximize surgical outcomes. So with this, thank you.
Thank you, Mr. Ng, for very comprehensive presentations. Kindly actually put your question in the Q&A box. We will try to answer your question after the sponsor videos. And so this evening, the sponsor video will be coming from actually Medtronic. Thanks, Medtronic, for the sponsor videos. And if you have any query about the sponsor product, kindly leave actually your message actually in the survey the sponsor will contact you directly for any query about the products. So back to Mr. Ng. Your patient must be the patient must be very lucky to survive, even though actually the patient was presented late. And I think the case actually was presented and was referred correctly to the person who is able to repair it correctly and nicely, and the patient actually finally survived without actually a rocky actually recovery periods. So there's a lot of questions actually posted by the participant. I was understand actually today we have actually a lot of participants from actually overseas, from Taiwan, China, Brunei, Singapore. So thanks for joining us tonight. To start off with, Mr. Ng, if you suspected actually esophageal perforations and the patient was started to show signs of sepsis, will you put in a chest tube first before you do an endoscopy to diagnose?
I will perform an X-ray first to look for any hydropneumothorax. If there's hydropneumothorax on this one particular side, I will put a chest tube first before I perform an endoscopy procedure to be safe.
Okay.
Alternative is to put the patient under GA.
And do you think actually it is wise to the people out there, if they suspected actually esophageal perforation, to put in a Ralph's tube before actually they send over the patient to you?
I would not advocate that, because I would recommend them not to do that and refer the case to the upper GI surgeon. Let the upper GI surgeons perform the endoscopy, and usually the NG tube will be inserted through a guide wire via endoscopy, rather than just a blind insertion that might end up in the operations instead.
Okay. And if actually the referral site actually referring you patients with suspected esophageal perforations, what kind of actually imaging actually you would like them to do, using a barium or using actually gastrography?
I will advocate. I will not recommend. Nowadays, I think CT scan usually they will use gastrography instead of a barium. Barium usually is for the oral contrast study. If CT scan, there's no issue with gastrography or barium. If they are going for oral contrast study, I will not recommend them to use barium, because barium is very difficult to wash out if the patient need to go for surgery later.
Okay. So there is a question from the participants. So there are many types of perforations. In cases of corrosive perforations, how would you approach these patients?
Okay. Corrosive perforation, first of all, we have, like usual, resuscitate the patient properly, find out the source of the corrosive, what kind of corrosive the patient has ingested. Is it acid or is it alkaline? And the investigation of choice is not endoscopy immediately. The investigation of choice is CT scan. CT scan will tell us whether the patient had just a mucosa injury, or worse is transmural necrosis. If the patient had transmural necrosis, from the CT scan, we will see non-enhancement of the esophagus wall. This warrants emergency surgery. If this is just a mucosa injury, then most of the time we can treat conservatively and expecting a stricture formation in the future.
If the patient actually does have a perforations, so most of the time actually you will divert, you will divert actually the perforations. So when do you think actually is the best time to reconstruct back?
Usually after the patient's inflammations or infection settle, I would say about at least after 3 months.
Okay. Yeah. Mr. Hans, any comment on this?
Reconstruction can be done anytime, as once the patient has recovered and has been nutritionally optimized, because the whole spell of this thoracic empyema usually is a major nutritional burden on the patient. So sometimes you'll notice that even 2 months down the line, patient is well, but has not put on enough muscle mass and such. And if you do a recon prematurely, you still end up with problems again. So it's important to look at the patient's nutritional status as also one of the parameters to decide when is the optimal time for recon. Of course, it's quite pitiful to see them with an esophagostomy and feeding through a feeding J, but this is something you need to pay attention to.
And what kind of actually reconstruction route you usually will perform? Substernal, actually cutaneous, or you still will go through actually the posterior mediastinum? Mr.
Question for me, Mr. Lim?
Yeah, yes.
Okay, I suppose it depends on the how bad was the inflammation at the original posterior mediastinum site. If there's an extensive fibrosis that really preclude excision, removal of the esophagus, I will do the recon at another way, for example, substernal or anterior mediastinum, instead of try to remove the esophagus and cause a lot of injury to the posterior mediastinums. Yeah, especially after corrosive injury, it'll be a bit difficult to remove the perforated esophagus after all the inflammation, all the infection subsides due to all the fibrosis set in.
So I suppose I think the substernal route actually will be usually the choice route, if you were to do recons later. So there's another question, if you suspected actually a esophageal perforation over the cervical, like in your case, which part actually, either you approach to the right or to the left? Which one actually you think is better?
So it depends on your endoscopy finding or CT scan finding. Endoscopy, you usually can see is the perforations on the left side or right side of the patient, one thing. The CT scan will tell you that which part of the neck is contaminated by salivary abscess. So that is the area that you would like to approach. But of course, sometimes you need to do a collar incisions to assess both sides.
If it's actually a thoracic esophageal perforation, how is your approach like? Anterior, posterior actually approach? Which way actually how you're going to approach through the chest?
The fifth intercostal space, posterior thoracotomy. That my approach for the the upper esophagus. For the lower esophagus, should be a 7-8 intercostal space on the left side.
Okay, Mr. Hans, your preference for approach?
Sorry, say again. For what?
For approach for the thoracotomy, for any repair for thoracic actually esophageal perforation.
I always like to go right because the left side has the heart in your way. That's one problem. But invariably, in most of these cases that I've had, contamination is bilateral. So I will open both sides and wash both sides. But I tend to prefer the right side for the repair more than anything else.
Okay.
You may need to resect one rib also because open thoracotomy through a narrow space, it's really hard. So just be willing to cut one rib off and give yourself ample space to dissect.
If the patient presented earlier with actually on a perforation and you attempted actually, you plan to go in to repair the perforations, how would you actually usually repair with? What kind of suture actually you usually will use?
It's usually absorbable suture. We use absorbable suture. We will try to repair in 2 layers and always expose the mucosa because the mucosa is not really attached to the muscle. So when there's an injury to the mucosa will tend to retract backwards. So you have to find where the mucosa edge is, then try to repair the mucosa before you repair the muscle. So the suture that we use usually is absorbable sutures. So we try to repair in 2 layers. If it's not possible, then take a good bite of the whole layers over a bougie. Ideally, should be tension-free.
So you always use a bougie to guide your repair.
Yeah.
Okay. If those actually places without a bougie, what will you advise them to use?
I suppose the hospital should have a OGDS scope. You can use an OGDS scope as a bougie, but you need another endoscopy to do that from above. So you can close it on the OGDS scope.
Okay. And in your case, you mentioned that actually they use a flap to cover up the defect site. Okay, to reinforce. Okay. Do you have actually any good experience using flap? And do you know any of the reason why sometimes the flap actually always fail, even though you take a good flap with actually good vascular pedicles?
I don't have personal experience on putting a flap on esophagus, but from what I heard from Mr. Hans, and the flap usually fail because it's repairing on a hotbed of sepsis. You know, the area is having is infected, then mediastinitis is going on. So any tissues that being pulled to the area, so you will get infected, and eventually the vessel will be thrombosed off and the flap will fail. So I suppose this is a reason that a lot of flap is not really working.
And you know, for iatrogenic perforations, you mentioned actually in your presentation stents. So usually the stent actually, you know, only applicable in those cases with actually cancer tumor, because you know that is the only place actually a stent actually will be, you know, suitable to sit on. Okay, Mr. Hans, do you have any good experience with stent in actually iatrogenic perforations?
The only time your stent will hold is if your repair was so tight that you've actually strictured the whole area. The stent will hold, but the repair will give way. So answer is no. So you know where I am.
Okay. So maybe we can take another questions. Mr. Hans, maybe you want to answer this. How you differentiate acute and chronic mediastinitis? One of the participants asked this.
Oh, the acute mediastinitis is, of course, you actually have contamination encompassing the mediastinum. The patient will obviously be in full-blown sepsis, and you will also see that there will be actually ECG changes with ectopics and such. There'll be irritation. So you've gone in, you've washed out, you've taken out everything. By right, the chest tubes are now clearing up, but you still notice that there is a need for inotropic support. The patient doesn't seem out of it. The septic indices don't really resolve despite the lungs being well expanded. Usually at this point in time, you're looking at something like post-op day 6, day 7, day 8. And that's when you usually put that this is chronic mediastinitis, whereby the problem with the mediastinum is it's relatively avascular. So the contamination is already permeated through, and that inflammatory component is not easily addressed. You can't really strip off the mediastinum. So this is where the antibiotic therapy support will have to kick in. Hopefully the patient recovers, because if it continues on, sadly, in this scenario, it's very high mortality. So it's not an exact time frame when you say this is acute and this is chronic. Usually after the initial intervention of washout and such, you expect the mediastinitis to go away. But should it persist after that, and in the absence where your chest tubes are actually all clear, you know that this is probably chronic mediastinitis. And it's actually a very bad complication. Happens because many of our patients are sent to us very late. With the mediastinum marinating in sepsis for 5 or 6 days, this is bound to happen. So that's why I refer to us early. There's no role for conservative management and sitting on the patient. It doesn't work.
Okay, we have many more questions to go. Probably in the interest of time, we take actually another one last one. In esophageal perforation, nutrition support is usually very crucial. So if you're able to perform actually a good repair and you're able to pass a route strip through, will you actually feed through a route strip, or will you still create a jejunal and feed the patient through the jejunal? Mr.
We will feed through the rice tube, and you are worried. I suppose you ask this question because you're worried that the rice tube will come out, then you have to reinsert again. But we have neonate scope. We will be able to put in the NG tube again if even the NG tube is dislodged. So this is not a major issue here. So we will be able to give the nutrition through the NG tube. So jejunal has its own complication, its own problem. So we don't advocate to do it.
Okay. So I think in the interest of time, we will thank everyone joining us tonight for this actually interesting topic, esophageal perforations. The key message I think Mr. Ng trying to pass over is have actually very high suspicious. If you have a patient, suspected actually esophageal perforation, make an early diagnosis and refer these patients early to an UpperGI center. And do join us again next week for our next topic on the 7th series, A Long Journey of a Short Bowel, going to be presented by Dr. Mohana Raja. Okay, So next week, same times, 8 o'clock on a Friday. So with that, thank you everyone, and have a good night.
Thank you for joining.
Take care. Good night.